Welcome to today's Cooperative of American Physicians webinar, Surviving and Thriving Through Healthcare Reform, How Physicians Get Paid. And we thank our sponsors, CapSource, CAP's free group purchasing program designed to reduce members' business-related expenses, and CAP Physicians Insurance Agency Incorporated, which offers physicians a wide range of business, professional, and personal insurance plans. And it's my pleasure at this time to introduce our presenters for today's program. Dr. Steve Casper is a board-certified family medicine physician and a longtime member of the Cooperative of American Physicians. At his Burbank practice, Dr. Casper has implemented a number of strategies to effectively work with payers to optimize the reimbursement process without compromising patient care. Dr. Casper earned his medical degree from the University of California, USC, and completed his residency in family medicine at Glendale Adventist Medical Center in 1991, where he went on to practice until 2010. Also with us today, we have Jeremy N. Miller, the founder of Miller Health Law Group in Los Angeles. Over the last 30 years, Mr. Miller has counseled medical groups, hospitals, and other healthcare organizations on organizational, operational, and regulatory matters. Mr. Miller is extensively involved in advising both his clients and the community on strategies for adapting to health reform and the rapidly changing healthcare delivery and payment system. To date, Mr. Miller has authored 6 articles, and he's made more than a dozen presentations on the new health reform law. A graduate of Northwestern University School of Law, Mr. Miller was named Healthcare Lawyer of the Year for Los Angeles by Best Lawyers in 2012. And also on our faculty today, we have June McKernan, who currently serves as Administrator for Patient Preferred Dermatology Medical Group in Los Alamitos. As a member of that practice's staff since its founding in 1989, Ms. McKernan has played an integral role in ensuring success of front and back office operations. Ms. McKernan has served on the Association of Dermatology Administrators and Managers Board of Directors as Annual Program Chair, and in 2014 was named their Practice Manager of the Year. So we have a terrific panel of experts for you today, and we'll begin our presentation with Dr. Steve Casper. Steve, welcome.
Thank you. Welcome to the webinar. I think you will find it useful and enjoyable. As Tim said, I'm Steve Casper. I'm a family practitioner in solo practice in Burbank, California. I have a unique perspective because of my background. I went to USC Medical School and then did my family practice residency at Glendale Adventist Medical Center. I started practice in 1991. I don't know if you were around then, but they told me that private practice was dead, that staff model HMOs were the wave of the future. Cigna, FHP, Aetna, Kaiser, they all had different plans, but they didn't work out. The HMO revolution turned out to be a rebellion, which is a failed revolution. I survived that. I continued in practice until 2010, where I joined the State Department and went to Addis Ababa, Ethiopia, as a regional medical officer. I survived that as well. In 2012, I restarted my practice, and I've been surviving. So I've been in practice for 23 years in various places, but I'm just starting out again as well. I have experience in my practice, but it's not closed, and it's still growing. I hear some of the same dire predictions now as I did in 1991. ACOs are the way of the future. Private practice is dead. The patient landscape is constantly changing. New payment models, ACO, accountable care organizations, IDS, integrated delivery systems, EPO, exclusive provider organizations, combined with old payment models, HMO, health maintenance organizations, PPO, preferred provider organizations, fee-for-service, FFS. And these combine with solo, small group, large group, and regional group practices. That's a lot of variables for us and our patients to navigate. But with education and understanding, we can help our patients deal with these complex issues. What has not changed is our focus on the patient, which is the key goal to surviving and striving in any payment environment. If we stay patient-focused, everything else will work out. This is a great opportunity for us as physicians to educate, counsel, and reassure our patients. They're sick, scared, sometimes in pain. We are the last line of defense. It is our duty to help them. Mass confusion about insurance stalks the land. I don't know how it was in your office, but when Hurricane Obamacare hit our office, we were swamped. Calls, visits, email. Patients trying to find out, are they covered? Are they not covered? Are they in plan? Are they not in plan? Where can they go for the information? We can help both our patients and ourselves by explaining to the patient how different insurance options affect them. As we educate the patient, we help to lice their anxiety and smooth out the reimbursement hassles. The patient may have difficulty understanding these critical components of their insurance plan: HMO, PPO, EPO, cash. How does it work? What is it? Where is it? Who is it? They also may be new to insurance and don't understand copayment, deductible, premium, out-of-pocket limit. Today, many more patients are in high deductible plans, which means they are more exposed to the cost of care than in the past. Provider networks. This has been a real cause of confusion. Are the subspecialists, specialists, and primary care physicians in the same or different plans? This needs to be addressed and is especially important in the elderly, who are often most confused about the insurance. This is a great opportunity for us to explain to the patient the options available to them, which leads to better patient care. If you and the patient focus on the medicine and not the insurance, you have better outcomes. This can also lead to less reimbursement hassles. Hey, in family medicine, it's all about prevention. How can we limit insurance confusion and maximize payment? The first part of this seminar really is about prevention. How are we going to prevent the problems from occurring? And also, when we explain things, it leads to an informed patient who is our ally to maximize reimbursement. When your patient trusts you and understands their plan, they're advocates with us for proper reimbursement. They're a potent ally if we need to go to the insurer or the other entity and seek reimbursement. In today's mobile and fragmented workplace, patients get insurance, lose insurance, and get insurance again, all within the space of a few months. Are we helping our patients make good choices about their insurance? It's a great time to explain to patients how we get paid and how they pay for care. A little bit of information can go a long way in alleviating the hassles down the road. Our first responsibility is to care for their medical issues, but we also need to educate them about their coverage for our sake as well as theirs. This limits the confusion, helps in the care of the patient, and maximizes our patient payment. When the patient understands the process, they are more satisfied with their care, and I think they get better outcomes. It's just one less thing that they have to worry about. They're sick after all. That's what we have to focus on. We have to help them through the insurance problems. How can this be done? I hear you groaning out there. You tuned into the webinar so that you get some simple answers. How do we deal with this environment? And now I'm telling you, you have to get an MBA or a master's in insurance. You're thinking, we don't have enough time as it is to do the things we need to do. My EHR is driving me crazy. I find no meaning in meaningful use. We don't necessarily understand the insurance any better than the patient is what you're thinking. What is an IDS anyway? Am I silver, gold, bronze, copper, aluminum? Where do I stand? We haven't been trained as insurance agents, and you're thinking, neither is my staff. All of this is true. We are physicians. Our first goal is medicine, but doctor means teacher in Latin. We have been trained to communicate with our patients. Simply answering their questions about new or existing coverage can reassure them and help them choose the right plan. The cheapest plan with narrow networks might work for the patient who needs multiple subspecialists, whereas a 25-year-old who is young and healthy may do fine in that type of plan. The thing we need to do is discuss with our patient, evaluate their needs, and help them understand what's the best plan for them. The more they know about their coverage, the easier it is for us to get reimbursement. Do they understand their premium? Do they understand the copay? the deductible, the out-of-pocket limits. Explaining how these work help the patient and avoid confusion. It also avoids the patient becoming upset. Patients do have some choice. Most patients are still getting their insurance through work, but even in the exchange, there are options. Are they choosing the best plan for their needs? And who better to help them than us? It's up to us as physicians to help them through this morass of confusion. The patient can choose a plan that gives them good care and us reasonable reimbursement. It's completely legitimate for us to explain to the patient what the plan limits and benefits are. And if you're in a plan that is not giving you the proper reimbursement, it's fine to discuss that with the patient. You'll find that as you get to know your patient over longitudinal care, as I said, they're your ally. They want what's best for them just like you want what's best for them. Now, we may feel overwhelmed for a variety of reasons. There's EHRs, there's difficulty with reimbursement, there's obviously keeping up just with the everyday medical things we need to do. So we can try to delegate. Educate your staff about copayments, deductibles, out-of-pocket limits, and how they can help the patient. It may be as simple as explaining what a copayment is and that it needs to be paid on every visit. Or it may be explaining to the patient who's never had a deductible before what a deductible is and how that works. Also, many patients get insurance, lose insurance, and get insurance. So they may be uninsured for a period of time. Explain to them cash options, including payment plans, so that no one is necessarily left out. We see many, many patients with a variety of different insurance plans. It's up to us to be familiar with the plan, perhaps not to the same level as our insurance agent, but be familiar with the plan enough so that we can give the patient good care. Don't be confrontational. The patient is most likely confused and is not trying to avoid paying you. I have trouble understanding the insurance plans, and I've been doing this for 2 decades. You can imagine what it's like for a patient who hasn't had insurance for a number of years and is suddenly thrust into this role. Insurance brokers and insurance companies often don't educate their patient, their customers, our patients, about what's going on. Remember, it is important to help the staff. You are the captain of the ship. A few words from you may be worth more than an hour of your staff's time. I had a patient last week who really argued with my front office and my medical assistant that he didn't need to pay his copayment. They went on and on, back and forth, for about 20 minutes. The medical assistant put him into the room, and we dealt with his medical issues. At the end of the interview, I simply explained to him that the copayment was due at the time of service and needed to be paid each time he was seen. He gladly paid the copayment. A few words from the physician are worth a lot. It's easy to yell at your front office staff or your assistants, but most patients will hesitate to do the same thing to you. Don't blame your patient because you signed a bad contract. We won't get paid for every patient we see, but we can't lose money on every patient either. We have to get reasonable reimbursement. If you find yourself lecturing the patients about your bad reimbursement, it's time to renegotiate or drop your contract. There was a subspecialist I knew who was a great clinician, trusted and respected in the community. But he had what we call at USC poor ICM skills, poor bedside manner. Every patient I sent to him came back to me and complained that he continually moaned about money. He wasn't getting paid by the insurance. He wasn't getting paid on time. Their insurance was bad. Well, I don't think when you go to the doctor you want to hear about how bad your insurance is. I had to stop sending him patients, and eventually he left the practice of medicine. Antagonism toward the insurer should never be directed at the patient. I know sometimes it feels like the patient is in cahoots with the insurance company, but they aren't. Like I said before, they're probably just confused. Don't take it personally, and use the time to discuss in a rational manner the options with the patient. We didn't get into medicine to deal with insurance, but we are better equipped than our patients to help them understand what's going on. Keep your eye on the ball. Remember why you became a physician. I'm sure it wasn't to deal with insurance hassles. It was to help sick people. If you give your patients good care and educate them about how the reimbursement system works, everything will be fine. Amaseganalu. That means thank you in Amharic, one of the languages of Ethiopia. I think now I'll turn it over to June.
Thank you, Dr. Casper. What I thought we should do today is just look at a little bit of the plan selections across the country by metal and how they were sold. So you can see here a majority of the patients chose the silver and bronze category, and that's due to them having the subsidies available to them. In California, we find the percentage of silver plans is still a little bit higher than that. So if patients are unhappy with their current plan, open enrollment is going to start on November 15th, and it goes through February 15th of 2015. So they'll need to enroll by December 15th to change their plans if they want a January 1st effective date. Last year, there was an extension given for open enrollment, but that's unlikely to happen this coming year. And by age group, as you can see, the younger group doesn't have the highest percentage, and this is kind of was the hope behind the Affordable Care Act. So it didn't happen, but then there were patients who did not have insurance. We're going to have penalties imposed. Penalties for 2014 were set at $95 for an adult and $47.50 per child, or 1% of the income. In 2015, we're actually going to see that increase to $325 per adult and $162.50 per child, or 2% of the income for not having insurance. No penalty is going to be applied if they're uninsured for less than 3 months. We were taught, one of the concerns we administrators have is what happens if they don't pay their premium. And the carriers still report that 80 to 90% of the new enrollees were paying their bills on a timely manner, which is similar to what it was prior to the Affordable Care Act coming into play. So it's turned out that it's not as big a concern as we thought. Imperative, number one, to verify patient eligibility. The patient eligibility is shows you, if they paid their premium, what their deductible is, what their co-payment is, and what the status is. If they're active, if they're pending, if they might have joined an HMO plan, a Medicare Advantage plan. So one thing your office should do, if it hasn't done, is implement verifying patient eligibility. It can be tricky to do it on the first of the month because you should verify eligibility on the first of each month. When we submit a claim to the carrier and it's denied, saying the patient's not eligible, if you have a printout of that patient's verification of eligibility, you can resubmit that claim, and 99% of the time the claim will get paid. With the second open enrollment fast approaching, it's necessary to re-verify patient status. And again, we do this on 100% of our patients every single month. Medical Group Management Association reported this past month that practices saw their bad debt increase to 14%. Because of this, practices have to change the way they're processing payments. Some practices are sending accounts over to a third-party payer much earlier. An example, you have a collection agency you work with. Some practices collect more up front, as Dr. Casper indicated. Collecting that copay at the time of service is imperative. And others are using a credit card on file for patient remaining balances. Again, there's some HIPAA concerns there, so you have to work with a company that can keep those secure. So it's strongly recommended that you have some sort of plan in reviewing your patient balances and collections. In verifying patients' insurance, though, you often see on or off exchange. And this has nothing to do with if it's an exchange plan or not an exchange plan. In many practices that I've done consulting with, they get so confused with this, including the sales agents, the brokers. This is simply how the patient purchased their insurance plan. If they purchased it on the exchange website or if they purchased it off the exchange through an agent. So it has really nothing to do with what type of plan that they have. 80% of patients in the state of California purchase their insurance plan through the exchange or through an agent off the exchange. So don't let this verbiage confuse you. Blue Shield removed some of this from the grandfathered plans due to the confusion, which was just a victory, and that happened just a few months back. There's still traditional patients that have the individual plans that are regular PPO plans. Not all individual plans are covered California plans. They all meet the the Affordable Care Act standards, but they're not all covered California plans. And then with hospitals, a little bit more work needs to be done here because you need to confirm with the facility that you typically refer your patients to that they are on these network plans. You can look at the websites, but when speaking to insurance agents out there, they tell us that hospitals have a lot more clout when negotiating their rates with the insurance carriers, and they're not always covered on all the plans associated with Covered California. They may only take a silver and a bronze, but they may not take a platinum plan, unlike the providers. Exchanges are not integrated with Medi-Cal. The Medi-Medi patients for 2015 are all going to be enrolled into traditional HMO products, and this is going to be new. So we've treated Medi-Medi patients for many years, and now you're going to have to verify their eligibility to make sure they haven't enrolled into an HMO plan prior to seeing them. And this should be completed by August of 2015. My understanding is they're enrolling these patients by their date of birth. There's going to be some fluidity from Medi-Cal to ACA plans depending on the income the patient's making and if they still qualify for Medi-Cal. Some patients were getting the subsidies on ACA plans. It was realized that they really didn't qualify. They should be on Medi-Cal, so their insurance has changed. So again, it just raises another case for verifying that eligibility up front. There's numerous pilot programs out in the marketplace to see if these HMOs will save money over the traditional Medicare, Medi-Cal plans, and the early results are showing that they, in fact, are saving money in the healthcare industry. Next, I think in regards to your insurance contracts, you have to really know what plans your practice has in place. So if you don't know, contact the provider relations at Anthem Blue Cross or Blue Shield and find out what plans are we on and make a list of those. Blue Shield, for an example, has 3 tiers, tiers A, B, and C. Tier C covers most of the Affordable Care Act plans. So, just basically know what you're contracted, make a list, keep them in your file. Blue Shield and Anthem Blue Cross are the only 2 carriers right now in using narrow networks in California. So the networks are much too narrow in some counties, and the state of California has really asked them to look into this for expansion because patients shouldn't have to travel hundreds of miles to seek and obtain services, but we're finding that's happening right now. If patients having a difficult time providing finding a provider, they're having trouble trying to navigate the insurance carrier website, they can contact Department of Managed Health Care. Here's the phone number you can give out to the patients. They're really helpful in supporting the patient to make sure they can get treatment. Providers, on the other hand, contact the California Medical Association if you're having difficulty finding where you or who you can coordinate patient care with. Anthem Blue Cross basically has 3 networks in California, the PPO, the HMO, and the EPO. All of these are identified when you verify eligibility as Pathway X plans. So if you see that it's a Pathway X plan, know that that is a covered California plan. And then you should know if you're contracted with them or not. In Blue Shield, they actually have 2 networks, the PPO and the EPO. The EPO is not available right now in Orange County. And these are a little bit trickier. When you go to verify eligibility, you'll be able to identify them as Ultimate, Preferred, Enhanced, Basic, and it will have that listed right before their plan, and if it has one of those names in front of it, you'll know it's a covered California on the Tier C. Blue Shield, you can easily print out a list of those plans. We keep a copy of that list at our front desk so the staff can refer to them should they forget. HealthNet, on the other hand, they sold products basically by the metals names, platinum and gold, silver, bronze. They're using their current network of physicians of 44,000 enrolled, and this was because most of the providers, when we signed our contract, signed an all products clause on that contract, and therefore allowed them to continue to use all their contracted providers with ease. And then lastly, I wanted to touch about the assignment of benefits. This is not really recognized in California when there's no contract into effect. So if you're not contracted on some of these plans, the payment when it's processed is going directly to the patient. With this said, Blue Shield had so many complaints that they are now processing the out-of-network plans and paying the provider directly. Yesterday, we actually had our first claim processed the same way by Anthem Blue Cross. So that's a real victory for providers, and thanks to the work of the California Medical Association working closely with these plans and the physician practices such as ours that complained all the time that, we have a hard enough time collecting the balances, never mind collecting what's being paid to the patients when we provide these services in good faith. But I need to add some caution here. When your posters, your people who are doing the posting of the payment from the carriers, these look and act like traditional PPO plans. There's an allowed amount, and the EOB looks like you're going to adjust it off. And if you read the fine print on the EOB, if you read the code that's attached and you read the last page, it says the patient's responsible for the full charge. So you do not have to provide an adjustment on these patient plans if, in fact, you do not have a contract. So some of the practices, they're charging the patient the full amount up front. Others are doing balanced billing and going after it at the end. Others, they're collecting a good portion of it, and hopefully the other portion will be paid to you. And if you collect too much because you collected that charge up front, and the insurance company pays you, it's very simple to issue a refund. I encourage practices to do it that way and run a refund report, sending it out. Sending a refund is much easier. So it's up to you what your office is going to do, but at some point you really need to have a policy so you can educate the patient what you're going to do, build a claim for the patient to make it convenient, and try to keep those balances at zero. And at this point, I would like to turn the last part of our presentation over to Jimmy Miller. Thank you.
Thank you, June, and welcome again. I'm going to be covering, of course, as an attorney, disputes. So how do we avoid them and how do we resolve them? So let's talk first about what are common payer disputes. We have a list here. Oops, actually, I guess my slide's not up. There we go. What are some common disputes that physicians get into with the various payers, governmental and private? Upcoding. If you bill every follow-up visit as a level 4 or level 5 and your notes all look the same, you're probably involved in upcoding. Lack of medical necessity. It's a basic requirement before you can get paid that the service you're providing is medically necessary. Many payer claims of overpayment involve lack of medical necessity. Inadequate documentation, the bugaboo of many physicians, maybe even harder with the EHR. You need to lay out what you did and why. Systems reviewed, complex decision-making, the complexity of the decision-making, how much time you spent, things of that sort. There's an old rule of thumb, if it's not documented, it didn't happen. Incorrect coding, obviously, as it suggests, you're not using the right code, and therefore you may get dinged on your for payment. Balance billing for in-network patients. Balance billing is prohibited. You're only allowed to collect deductibles and copays. If you surcharge your patient, you're at risk. Using the incorrect site of service refers to physicians, for example, who are working in the hospital setting and having a consult or a visit in the hospital inpatient or outpatient department. That cannot be billed as if you were seeing the patient in your physician's office where you would get paid more for the same visit. Non-covered services can include things like experimental treatments or cosmetic procedures. Some people will try to claim, for example, that a rhinoplasty was really for a deviated septum. That would be cosmetic and not payable. Additional areas where people get into trouble are not charging required copayments. It's okay to not collect a copay if the patient literally cannot pay and you make some reasonable effort to attempt to collect. But the routine waiver of copays or deductibles can violate both your provider agreement for commercial payers and it could be illegal. Aetna currently has a big lawsuit against various surgery centers claiming that they're waiving out-of-network payments constitutes some type of billing fraud. We're involved in that case. We don't think that's true, but Aetna has raised a very large lawsuit. Failure to get pre-authorization for the service that you're going to render for a procedure, a test, a surgery, obviously that's a direct road to not getting paid. Unbundling services, so if you're a surgeon, you get paid based on a global period that includes certain pre- and post-op services. If you try to bill separately for those pre- and post-op services, you're engaged in illegal unbundling. Billing for unenrolled physicians. You hire a new physician. That physician doesn't yet have his or her Medicare or Medi-Cal number, and you bill under your number until they get their number. That's a no-no, and you can obviously get into trouble if you do that. You are allowed to bill retroactively up to a point. Once you get your application into Medicare, for example, you can bill up to 30 days retroactively prior to the application being submitted. Some people, when they open new offices, they forget to notify Medicare or other payers where required that they have a new location, and sometimes they'll use the old location address instead. That gets you into trouble. HCC coding refers to hierarchical condition categories, which is a risk adjustment factor for capitated enrollees and a way for people to get additional payment for senior lives. You have to be very careful that you have documented the basis for the higher coding categories, and there's a lot of scrutiny by Medicare of this. Incident 2 billing refers to when you're billing for a non-physician practitioner like a physical therapist or a nurse or a PA. Those folks, otherwise, if you bill under their numbers, will get paid 85% of the Medicare fee schedule, whereas a physician, if they can correctly bill them as Incident 2, the physician's services, the payment will be at the physician's 100% fee schedule amount. But there are requirements to be able to bill Incident 2, including that the physician see the patient first, be involved in the care, and provide direct supervision, meaning the physician's in the office when the mid-level practitioner is providing the services. Okay, how do we avoid payer disputes of the type we just covered in the first place? It's one thing, it's bad enough not to be paid for your services, but I think it's even worse when you're paid and now somebody is asking for money back. And that's what most of our presentation here is covering, our money being clawed back or attempted to be clawed back by the payers. What may seem strange to say, the good news is that most of the problems that physicians have with payers are really self-inflicted wounds that can be avoided, and we're going to talk about how that's possible. First, your billers need to understand what they're doing. Frequently, people, particularly in small offices, get pressed into service who don't have a real coding background. Coding obviously is critical and needs to be done right, so you need to have people who know what they're doing to do it, or hire an outside billing service that knows what they're doing. You as the physician can't just say, well, if there's a problem, my biller did it, I didn't know what was going on. You have to be involved. It's being billed under your number, it's being paid to you, and if money has to come back, it will come out of your pocket. So you have to be engaged and knowledgeable about the process and what's being done in your name and under your number. When it comes to E&M coding, where a lot of overpayment disputes take place, you need to understand what are the required elements to bill a level 4 or level 5 for a follow-up visit. It's not enough to just put down a 4 or 5. You have to understand, again, that there are requirements for how many systems you're reviewing, the complexity of the medical decision-making, the time you put in, et cetera. A lot of physicians get in trouble where they routinely use these higher E&M codes. Documentation, again, really critical, because if you don't document it, if you get questioned or reviewed, you're not going to be able to prove why your coding was appropriate. Particularly in the age of electronic health records, you need to avoid using templates or engaging in what's called cloning, where you copy and paste notes, because if you do get reviewed and all of your charts look virtually identical for the visit after visit, that's going to look quite suspicious. Workers' comp, I know we have a question, I think, about workers' comp. One thing I'm going to say about that is you have to be very careful to make sure you have all of your legal status in order. The carriers are always looking for a way not to pay workers' comp claims, and that may be something as ticky-tack as not having a fictitious name permit in order. Let me go to the next slide. Continuing on how to avoid disputes, keep in mind you don't have to downcode to be safe. You're not going to get in trouble if there's a legitimate dispute over whether it should be a level 2 rather than a level 3. So do what you think is justified, understanding what's required for the code. If you get requests for records, don't ignore them. Some people just put them in the desk drawer and they get into trouble because they haven't responded on a timely basis. Don't give it to the person who makes the least amount of money in the office to do it. It should be handled at a high level to make sure that you're getting all the requested information in and that it's presented correctly. You should also periodically conduct audits of your office, either with the personnel who you have, or hire an outside auditing firm to come in and help to determine whether your coding and billing is in order. Also, beware if you're being sold a medical device by a sales rep and they tell you this is how you need to code in order to get paid. It should be obvious what the code is, or it's likely that you're going to have a dispute later on down the road. The Medicare 60-day rule is very, very important. It's one of the most insidious things from the Affordable Care Act when it comes to payment. The rule basically says, with respect to a Medicare patient, that if you find you're in possession of an overpayment, you identify that you have an overpayment because you find later on that you weren't entitled to the money. It used to be that you would decide, well, I'll wait till they ask me for it. Now, if you keep that money and don't repay within 60 days, having identified that you have the overpayment, each of those claims becomes a false claim with tremendous penalties that apply. So if you suspect you have some overpayments, you're going to need to conduct an internal investigation to determine the extent of the overpayments you're in possession of. You may have to hire a specialist to do a random sample and then present that. Some people may think, well, if I don't know about it, if I stick my head in the sand, then I'm safe, but you don't want to have problems in your office going on without your knowledge. You should be still doing regular internal auditing. If you have to repay money, then you're going to have to determine, hopefully it's something that just happened through a mistake, and you can just write a check to the carrier, as opposed to if it's due to some kind of fraudulent activity, then you're going to have to make a self-disclosure to the Medicare program. Okay, let's move into resolving disputes. First, we want to determine whether the dispute is of a routine nature or something more serious. One way to determine that is who's asking for information. If the carrier sends you a letter asking for 10 to 50 charts, that would be more in the nature of a routine inquiry. and then they usually get the charts, and some number of months later they'll send you some letter determining whether they think there's an overpayment problem or not. If you get the letter from the carrier but it's from their special investigation unit, that suggests they think there's something more than a routine overpayment issue. If you get a subpoena from the Office of Inspector General, then obviously the threat level has gone up quite a bit. And last, of course, would be if there's a search warrant or raid of your office where they come in with the blue jackets with the 3 letters on the back, then you know you've got a problem. Okay, assuming that you're in a routine payment dispute area, then it means that's potentially having to return money. It starts with, they say, a record request, and then what they'll do if they think you owe money is they'll take that 10, 20, 30, 50 record request and they'll extrapolate it over the universe of claims that are at issue. So that doesn't mean they're only going to limit it to the number of claims that they did the focused review on. Always respond on a timely basis for requests for records. Don't ignore them. Avoid the temptation of altering any records, saying, gee, I should have put this in or that. And you can supplement records, but you have to indicate the date that you supplemented them. Remember, you've already submitted the records in many cases, so if you change them and don't indicate when you did, they're going to find out very easily. This is also an opportunity to provide background information where you can explain things that may not be clear in the record. The carriers aren't necessarily looking to screw you here, but you need to do whatever you can to help yourself. Again, treat this as a high-level priority and give it the attention that it's due, and always try to resolve any disputes with the payer as quickly as early as possible, because once it gets further up the chain, if you lose a case, then you get into the appeal process, and that's more problematic. So here on the next slide, if it still is a routine payment dispute, but the carrier says we've determined you owe us money, then you're going to have a right to appeal. If it's a commercial payer, look at your contract. It'll spell out, or you can otherwise get from the carrier, what your appeal rights are and what you need to do to appeal. If it's Medicare or Medi-Cal, you also, of course, need to know what you need to do to appeal. One thing you should be aware of, a change in the Medicare law, which is helpful to providers, that if you properly, on a timely basis, file an appeal of a Medicare overpayment determination, if you get your appeal within 30 days of that determination, then Medicare can't start recouping money from you by future payments you otherwise would be owed. So obviously very important to stop that clock while you can, but keep in mind interest will be accruing in the meantime. The payers can go back in California for at least a year, unless they can show there's fraud or misrepresentation. On the federal side, they can go back at least 4 years and even longer if they can claim fraud. Avoiding ineffective combativeness refers to don't just assume they're wrong, that you're being picked on, and flip them the bird. You really need to work with them to try and get things resolved as quickly and at the lowest cost possible. We had a case involving a large university where I called the SIU, Special Investigative Unit guy at Anthem Blue Cross, and when I told him I think, we have made a mistake, he was shocked, and he eventually said, I've never had anybody admit that maybe there was a problem and didn't fight me, and we got off essentially scot-free. Retain experts if you need them to help to support things like medical necessity determinations. The next slide in resolving disputes, I have a little bit of time to talk about what if you're not getting paid as opposed to if you've been paid and trying to get your money back. Help yourself by submitting complete claims with all the information that the carrier needs to determine whether they're liable for payment. There are the prompt payment laws. The insurance companies have 30 working days to pay, or interest accrues. HMOs and IPAs have to pay within 40 days, assuming they have complete claims. Repeated requests for records are a pain. They're not supposed to do that unless you haven't provided the information needed. Don't blow any appeal deadlines, obviously, because then you lose your rights. Generally, you have 30 working days to contest in writing and with the reason for you're contesting it. And always, of course, prepare your case very carefully, get assistance to do that. Billing fraud, this is another order of magnitude. This is where it's no longer routine, but where there is a claim that you intentionally and knowingly submitted false claims. This is not an innocent mistake, but something where somebody knew that they weren't entitled to the payment, but they billed it anyway. Examples that I've cited: if you bill for services that were never rendered, you knowingly provide unnecessary services, and you routinely upcode for E&M coding, for example. Penalties can be very, very severe, whereas the overpayments usually pay the money back. In this instance, you could have to pay not just the money back, interest, fines. There can be treble damages, 3 times what you were paid. Per claim penalties can be thousands of dollars per claim. You can be kicked out of the Medicare or Medi-Cal programs, and you can go to jail. Very, very severe. These cases, as I indicate, instigated by Medicare Office Inspector General, for example, various carriers, the ZPICs, subpoenas, and raids. Keep in mind that simple mistakes are not fraud, but fraud is not a simple mistake. You really don't need a lawyer to know that. But if you do get investigated for a fraudulent claim, you need to get a competent healthcare attorney rather than your brother-in-law to help you out. Okay, my concluding slide is that the good news is billing problems are largely avoidable. If you're educated, your staff and yourself, you don't engage in risky billing practices where you really should know that you're asking for trouble. And if you do get an inquiry from a payer, that you respond carefully and timely. If you use common sense, you'll be okay. With that, I'll turn it back to our moderator, Tim Wilson, for questions.
Okay, well, thank you, Jeremy, and thanks to all of our speakers. We covered a lot of ground, a lot of terrific information. And before we get into question and answer period here, we've had numerous inquiries about getting a copy of this presentation. And I do want to pass along that the slides for today's webinar will be emailed to you quite soon. So you can use that as a reference in case you missed something. So again, we will be emailing you the PowerPoint slides for this presentation. But right now, let's open it up for questions. If you have a question, type it into the general chat tab. The line below that, either hit enter or send. And we do have quite a few questions already. So let's start at the top here, saying, and this one is for June, asking, how do you sign a good contract that will give you reasonable reimbursement? Kind of a general question, but any details on that?
Well, that's $1 million question.
Yes,
right there.
It is.
Every time you get an insurance contract, you need to review it. It's great if you have a healthcare attorney that can review it for you. I know the CMA has done a lot of contract evaluations on their website, and as a member, we can always refer to some of their evaluations. The terms and terminology sometimes can be quite vague or confusing, and sometimes that's very intentional. This is why we need more expert care. And then you want to look at the rates of reimbursement. If there's any carve-outs on that contract, definitely you want to look at the termination clause in any contract. I think that's a big one. And a lot of them will have an automatic rollover, so it extends the length of the contract. So there's a lot to evaluate in it. It's not just say, oh, they offered me a contract and sign on the dotted line. You really need to read it and understand the terms within that contract.
Okay. A quick question here for Dr. Casper asking, can any MD make it without joining Obamacare?
Well, that's interesting. It really depends on what kind of physician you are. Are you a generalist or a subspecialist? Are you urban, rural, suburban? How many patients do you have? What part of your career are you in? I think it's possible to survive and thrive either with or without the ACA. I think it's really just a matter of trying to figure out where you're at and how many patients you see, how many patients you have, and trying to figure out, is that the best thing to do? I think that a better way to look at it is, what's the best way for us to survive and thrive in the environment, instead of us pulling ourselves out of the environment. So.
Right. Let's take a look at a little more specific question. This one's for Jeremy, asking, if an insurance company duplicate pays on a claim, is it better to notify the insurance company with a letter requesting they send an invoice for the overpayment, or send a letter with a check and hope they correctly apply the money to the patient's claim?
Well, if the insurance company pays the claim twice, then it should be refunded to the insurance company. And you just want to make sure that you get credit for that so they don't later claim that, hey, we found out we paid you twice, and you say, well, I refunded, and they say, where's the evidence? I mean, there should be a canceled check, but I don't think the patient needs to get involved unless the patient's entitled to some refund for some copay.
All right. And another couple of questions for you, asking, at what point in this process should I involve an attorney? And if I need one, how do I find one?
Well, I guess I have to take that one. I can't just say early and often, but it depends on If you're getting any, I think it's always good to touch base with your attorney at an early stage when somebody's asking you for money back or investigating you, and your attorney at that point may say, hey, there's not much to do, send the records, and then let's see what we get back. But an ounce of prevention is worth a pound of cure applies in the legal world as much as in the medical field.
All right. Another question for Steve asking, has anyone hired an employee just to be an insurance liaison or educator? And if so, has that proved beneficial to the revenue collections?
I don't know of anyone who's done that. Certainly that what you could do is, as I was talking about, is delegate some of that responsibility to part of your office staff, because they're answering the phones every day. They're taking questions from the patients. But ultimately, also, like I said, the physician is the captain of the ship, and if there's some questions that are easily answered, a lot of times it's the physician takes 5 minutes to do it, as opposed to the staff taking a half an hour. I think you'd have to be a very large group to have just one employee solely dedicated to insurance.
All right. We have a couple of questions here for June asking, how do we enforce that we do not have to accept the discounted fee for plans that we are out of network with? And is it possible that we have become automatically in network in some of these plans? And if so, can we stop being in network with plans we don't want to accept the contract for? Kind of a lot of question there.
That is a lot. Basically, patients do look to their providers for their answers regarding how their insurance works. And so it's, we've taken on a role, as Dr. Casper said, where we have to provide a lot of patient education in this area. So we just let our patients know. Unfortunately, we're not contracted with your carrier. However, if they're a Blue Shield patient, we let them know we're not on this plan, but they will pay 50% of the ACA rate, and that will be paid directly to you. So this is your charge today. We ask for full payment up front. We bill the insurance for them, and whatever they get, they get. And that has worked. We just have to educate them. And then the second part of that question was can you repeat that second part, because I think I forgot it.
Let me go ahead and find that here. Sadly, I did delete the question to clean things up, but I think I should be able to recover it here. Yes. Is it possible that we have become automatically in network with some of these plans? And if so, can we stop being in the network with plans we don't want to accept the contract for?
Sure, because a lot of the contracts that we currently have in place, there was a clause in there was an all-product clause. And so you can look at your existing contracts, if you still have them in your filing cabinets, and find out if it's an all-product clause contract. And if it is, you probably were enrolled in some of these plans. Blue Shield, it was a separate agreement that you had with them. And if you want to be out of the plan, you probably most likely will have to disenroll from the plan in its entirety if you signed an all products clause, and then find out if that insurer or the payer has a new revision contract that they can take that clause out of it.
We have a good question here for Dr. Casper asking, how do you get insurance companies to negotiate on rates? Seems as a solo practitioner there's very little leverage.
We do have little leverage, but what we do have is a strong ally in our patient. So if you look at the rate and you can't make money on that at that rate, it's time to think about dropping the contract. And the best thing to do is to discuss it with the patient. So if you have a patient that's signed up with Deny Me Care, and they come in and they don't pay you, they pay you late, they are resistant to paying you, and it's perfectly fine to discuss that with the patient and say, perhaps there's another option here that you can do. But you can also go directly to the insurer and say, I have X number of patients, this is a good service I give, and you guys are not paying me an adequate rate. The only thing they can say is no.
All right. Question for Jeremy. Does the incident rule apply to only Medicare and TRICARE patients, or does it apply to all insurances?
I'm afraid I'm not sure the answer, whether it applies beyond Medicare and other federal health care programs. I've not had that come up with commercial payers. So I'm sorry, I don't have an answer, but if somebody will try to reach me offline, I can try and find it out for them.
All right, another question for you asking, in California, when does the 1-year clock start?
The 1-year clock for when they can ask for money back starts from when you get paid. So if you're paid today, October 30th, and they come knocking on your door November 1st, 2015, you would argue that they knocked too late in the case of a commercial payer, unless they can prove that there was some fraud or misrepresentation involved.
Okay. Here's a question for June McKernan. And June, the question asks, Medi patients will all be enrolled into a traditional HMO plan later in 2015. Now, does this mean that we won't encounter this MC-MCAL combo anymore? And what about MC with a non-Medi-Cal secondary?
Okay. Your traditional Medicare patients with a secondary payer such as AARP, those are fine. You'll still be able to treat them. Many patients in California is going to disappear during the course of 2015. So all your Medi patients will be either in a traditional HMO or on a Medicare Advantage plan. So, yeah.
And another question for you, June, asking, do you recommend that we contact provider relations with all contracted plans? Only BS and BC are being specified.
Right, because Blue Cross and Blue Shield were noted for having the narrow networks in California, and so some confusion for practices were whether or not they were included in those narrow networks. So if you didn't know, you would contact provider relations and they can let you know. The other ones still had open networks, but if you're not sure if you're on the network, on a narrow network plan, contact that health care carrier and you'll find out if you're on it or not. They'll be able to direct you.
And we have just a couple of minutes left. Another question, and this one's for Jeremy. And it says, I've had insurers who want their money back because of overpayment 2 years after the payment date. Now, how do you fight that?
Well, if it's a commercial carrier, then you would cite the insurance code and say you had to ask for money back 1 year later. There's been a big dispute between the CMA's trying to help physicians, where the carriers will say, well, that 1 year rule applies unless there's fraud or misrepresentation. So they've tried to abuse that exception to get around the 1 year rule. But generally, you'd write them a letter to explain that it's past 1 year and there's no fraud or misrepresentation.
All right, and had a couple of questions regarding this, and this is for June. Is there a good summary source to use as a reference for elements required for levels of E&M coding?
Absolutely. Your CPT code book, it explains it in great detail in the blue pages in front of the book, and you can read that, and it will tell you, like, history of present illness. For a focus visit, you need 1 to 3 elements. For a detailed visit, you need 4+ elements. And then it will also tell you, go through examples of medical decision-making, whether it's low level, medium level, or comprehensive level. So read the information in the front of the book, and it gives you plenty of examples on there.
All right, and sadly, the clock is relentless. We are out of time for questions, but I want to thank each of you for a very informative, terrific presentation today. And with that, that concludes today's Cooperative of American Physicians webinar, Surviving and Thriving Through Healthcare Reform, How Physicians Get Paid, presented by Dr. Steve Casper, June McKernan, and Jeremy Miller. And thanks again to our sponsors, CapSource, CAP's free group purchasing program designed to reduce members' business-related expenses, and CAP Physicians Insurance Agency, Incorporated, which offers physicians a wide range of business, professional, and personal insurance plans. When I end the webinar, your computer will be redirected to an online evaluation form for today's program. We very much appreciate your comments and suggestions so that we can bring you future quality programming. Today's program is copyrighted in 2014 by the Cooperative of American Physicians. All rights reserved. Thank you for joining us today, and enjoy the rest of your day.
The information in this program should not be considered legal advice, applicable to a specific situation. Legal guidance for individual matters should be obtained from a retained attorney.